Good morning, everybody. I'm Christine Bechtel with X4 Health. We are a purpose-driven organization founded by two consumer advocates and a nurse. We work on complex problem solving inside and outside of our healthcare system, use a lot of human-centered design work. I'm really excited to be here with you guys today. I think it's so appropriate that when we're talking about a person-first healthcare system, we actually have not one but two panels talking about how do we engage individuals and also communities in co-designing a better healthcare system. And what I love about that is, as Stacy said it actually on the last panel, he talked about leveraging the individual level with enough kind of mass to have some teeth at the systems level. And I think that's a lot of what you're going to hear from this panel today. So I'm joined by Brandon Wilson. He is the Senior Director of the Center for Community Engagement and Health Innovation at Community Catalyst, which is a great consumer organization. I'm also joined by Dr. Clay Marsh. He is the Dean and Executive Dean and Chancellor at West Virginia University, the Health Sciences Division. And then Dr. Mai Pham, who is the CEO and President of the Institute for Exceptional Care. So we're going to start out today just asking these three fabulous humans to talk a little bit about some examples from their own work that really are exemplary of great community engagement. So start with you, Brandon.
Sure, thank you. As mentioned, I'm the Senior Director of the Center for Community Engagement and Health Innovation at Community Catalyst. We are a health advocacy organization. When we think about community engagement as a model, there's many out there. Ideal models would be dynamic, would allow for some type of agility to it, allow us to learn, to relearn, to do some unlearning. I'd even push back on the notion that we're trying to get from point A to point B, some type of linear model there. There are many that involves things such as community input, involvement, collaboration, communication, even co-design. But we try to center our community engagement work on four important principles. The first is power imbalances. It's really important to recognize who we are as institutions, how we show up, how we could have even caused harm in communities, the power imbalances between institutions and communities, and even between some institutions. Also, investing resources. If we agree that there are some structural barriers, particularly disinvestments into certain communities, which have actually caused many of the disparities and inequities that we see, then on a flip end, that means it must be equally important for us to proactively invest into these same communities. Respecting diversity and cultural humility. That may look like we may have to yield to community voice and perspective on what engagement actually looks like, how it's conducted, what that process is, what the outcome is. And then transparency and inclusion, being really intentional about including diverse communities and those who've been systemically underserved, disinvested, and quite frankly, even harmed by the status quo of our healthcare delivery system. And because I'm a professor as well, I can't answer this question without bringing up models and framework. I think we've talked a lot about probably systems thinking already. But when I think about that, I think about social systems theory or social ecological framework, starting with the individual and looking at that interplay with small social networks, whether it's families or friends, organizations, to community and policy. And I think there's an interplay between all of those dynamics. With that said, if I can think about the policy level, at the center, a really good example is we had found that it was really effective with organizations to actually employ or to have community advisory boards so that you can hear directly from patients, families, communities, and to institute some form of quality improvement there. When working with CMMI previously around the Financial Alignment Initiative, we found that really effective to hear feedback on how it was or was not working well to advance quality and well-being for dually eligible beneficiaries. With some administrative advocacy involving community around that, we were able to successfully advocate to CMS MMCO office or Medicare Medicaid coordination office to then require enrollment advisory councils, also CAPS basically, for all D-SNP plans. So I think that's a really good example of how to bring community along on a systems level or policy level in a way that's actually beneficial.
Thank you, Brandon. We're going to unpack, there's a lot there. We're going to unpack a little bit more of that in a second. Dr. Marsh.
Clay. So thank you, Christine, and it's really wonderful to be here. Let me start to frame my comments with some facts around health in America. So we lost 2.7 life years during the COVID pandemic. Other countries dropped initially, but then have picked back up. We spend 1.5 times as much as the next country in healthcare, which is Germany, and spend twice as much as the average Western nation in healthcare, but we have the worst durable outcomes of any country in the world. And if you are a child born today, you have a less likelihood of reaching 10 years old than if you're born 4 years ago. And that's the first time that's happened in our measured history. So we are spending a ton in healthcare, but we are not getting the results. And the question is, to me, why are we not, why are we not getting the results? And the answer is that we operate in a sick care system. We are a rescue from failure care system. And when we start looking at how we can improve that, really, to me, there's two things that are front of mind, and it's partially because of the experience we've had. Number one, we are now looking at starting with our academic health system, which spans now 24 hospitals in West Virginia, some in Ohio, some in Maryland, some in Pennsylvania. But we're looking at starting an insurance arm of our health system. And the reason why we want to do that is because we want to balance the costs of supporting people and supporting their health. And to me, I want to flip really quickly, because I know our time's limited here, but to talk just for a second about what we perceive as health and why interfacing with communities is so important. And to me, health, and you can define it a lot of ways, but is where your biological age is as low as possible versus your chronological age. So the younger your body's real age is versus your birthday age, the healthier you are. The older your body's real age is versus your birthday age, the less healthy you are. And the things that make us healthy, if you look at that, if you believe what I just said, then longevity to me is a great correlate for health. Because if you live 100 years, presumably your body's real age was pretty good to allow you to live for that many years. And if you believe that, the things that make us healthy are not so much, your screening exams, et cetera, which are important, but it's really about your connections to other people, your sense of purpose, the fact that you have a reason to get up every day and you continue to be challenged through your whole life. And we saw that most certainly during the COVID pandemic, and I had the opportunity to help oversee our COVID response of West Virginia, and we worked as a team. We even created a group, and it was really out of the team of teams model of Stan McChrystal, where we had stakeholders from every area around the table. And one quick example of how working with our partners, our community partners, and our people at the point of contact for patients, when we looked at vaccines coming out for COVID, the country had the federal pharmacy program, which basically programmed all of the vaccines through CVS and Walgreens. But we knew in West Virginia that we didn't have CVS and Walgreens on corners of small rural parts of our community. And because we had the Pharmacy Association, the Long-Term Care Association, the Hospital Association, we learned that family and private pharmacies had pre-existing relationships with our long-term care affiliates. And we then, by going to the federal government and telling them that we weren't trying to be obstinate, we just didn't think this would work for us, and we didn't activate the federal pharmacy program like other states did. We used our relationships. We used our family and privately owned pharmacies, and we were able to immunize our nursing home population, long-term care population up to 2 months before other states. And we were able to get the second vaccines in people's arms sometimes before other states had gotten the first vaccine in arms. And I'm not saying that because look how great we are, because we certainly ran into the wall that everybody else did after a while. But it really helped us understand that the more we could communicate, the more we could use the people that really had the knowledge and start to do things in rapid cycle learning cycles. And the last thing I'll say is there's an author named Nassim Taleb, who I think is brilliant, wrote The Black Swan about asymmetric risk factors. He wrote a book called Anti-Fragile, and he said that in complex systems, which certainly is what we're dealing with, the only way to buttress complex systems, make the systems more resilient to stress, is have bottoms-up approaches. So multiple learning cycles, rapid learning cycles, so you could try ideas, you could test them, you could see what happened, you could iterate them, you could kill them, you could continue them. But that's the way that we're really trying to all work together now to make health better in West Virginia. Thank you.
Thank you. Dr. Pham.
Why? So I would so love to geek out with you guys on the theory and the abstractions, and we're going to do that offline. But just for context, Institute for Exceptional Care is a nonprofit committed to making healthcare better for people with neurodevelopmental disabilities like my son, Alexander, so that they can live life to the fullest. We had the challenge of founding this organization, coming to it as health system experts. I'm a former chief innovation officer at the CMS Innovation Center. I was the ACO primary care lady. You can also blame me for the first macro regulation. And yet, we've also recognized that for most people with intellectual developmental disabilities, IDD, healthcare is considered primarily as a source of harm. So we asked ourselves, how do we build this bridge? How do we become the bridge between healthcare and this community? And we felt our way through it. It was a vertical learning curve. So let me paint a picture for you about what it looks like today after all our learnings. Every single project that we do to address system gaps, abstract system gaps, like we're not measuring the things that matter, we begin by bringing together community members who have the disability, family members, and then we put them in the same room with really important healthcare decision makers, like many of you, federal policy leaders, health insurance executives. And then several things happen. First, we level the playing field. We try to flatten hierarchy as much as possible. Nobody talks about their degrees. We share what sheep we are on the sheep scale of emotions for that day, right? We might talk about our favorite breakfast food as an icebreaker. We also deliberately support the community members because it is intimidating to walk into a room like this. And it's supposed to be intimidating in the other direction. We are supposed to be intimidated by them because they have wisdom we know nothing about, whereas they can see our wisdom. It's very transparent, right? So we do things like offer pre-meeting videos to explain what's going to happen and the issues. We offer them one-on-one prep calls where we can start to document their early thoughts as they begin processing their points of view. We use graphic illustration. We use extreme plain language. We run for their review through multiple attempts to get just the essence of what it is that's important to them. So an example of how this results in a better system is that many of us saw the need, as Elliot mentioned in the last panel, to actually measure things that matter. And we thought, well, we could sit here and impute what we think matters from a patient perspective, or we can just ask people. So through a process that involved a core team of stakeholders, with representation from, it's the 5 Ps, people, their care partners or givers, providers, payers, and policymakers. 1 representative from each stakeholder group on the core team. Then an advisory group with 3 representatives from each of those groups. Then focus groups with 90 stakeholders where we began with, we call people with IDD self-advocates. We got the self-advocates. We had one-on-one sessions with them with a graphic illustrator, and we asked, tell us your health story. What does being healthy mean to you? What does not being healthy mean to you? We finished all those, then we brought them together in a focus group and asked them to help consolidate the priority themes and what they felt was needed to help them get to those outcomes that matter. Then we pivoted to the second P, the care partners, caregivers, and we said, you don't get to take anything away from what they said. Here are their illustrations. But what would you add? And we documented that. So it became this cumulative spiral of graphic illustration summaries. Then we turned to the providers and we said, you definitely don't get to take anything away. But how can you best support these priority outcomes? And what resources do you need to do that well? Then we turned to the policymakers and the payers and we said, definitely not taking anything away, but we recognize you also have needs. How can you best support the people, the care partners, and the providers in doing what they need to do? After which we ended up with 9 domains of outcomes that matter and a multitude of elements of how you get to those outcomes. And then we held groups, a working group, 4 sessions with them to help prioritize among that list. When I tell you the domains were good physical health, which to them means maximal energy, minimal pain, good mental and emotional health, sexual reproductive health, right? System supports, resources for payers and regulators to do what they need, a workforce, a clinical workforce that is adequately prepared. There are 2 more. What is it? Middle-aged brain. But the point is, if you heard those outcomes and you looked at the elements, what you would see is like 96% of them are not IDD specific. It turns out that when you ask real people what is important and how to get there, you learn just what human beings want. You have now developed a universally designed set of outcomes that are widely applicable because you bothered to not just listen, but to hear and to leverage everything that you heard and engage them in a power-sharing structure that was as even and inclusive as possible in concrete, measurable, process-oriented ways. There is no genius about it whatsoever. What we notice coming out is that the community members feel empowered because they have never had access to the levers of power like we give them. They thirst for it. That alone generates dividends because you wouldn't believe the kinds of personal networks that people with disabilities and community members have. It reverberates throughout all their networks. So that little bit of investment that we made in trust building, we get returns many, many-fold back. Now we have wait lists to get into our projects from community members, from people we don't know who they are across the country. On the provider and system side, they walk out inspired and relieved because the implicit message here is it's not all on you to solve the problem. You have community partners who can take some of that off of you. You're not supposed to have all the answers. It's okay to not be perfect. And they feel liberated because we have returned some humanity to their work, reminding them the reasons why they went into this. They too need liberation, as Stacy said. They feel terribly constrained in where they are. Then we notice they become addicted. So when we roll out this health outcomes framework at the end of the year for public comment, it will have passed through, we actually next Tuesday we have our final meeting. It will be in person to cement the goals for these 26, we got 100 plus down to 26 key elements, right? National goals we'll put out. 3 federal agencies invited themselves to the meeting. We didn't have the slots. And then one of the agencies wanted to bring 5 people. We said, really kind of not, because we can't have self-advocates grossly outnumbered. But that is how addictive it is. That is how thirsty people in the system are to hear from people who are being harmed by the system. That is how you rebuild trust, is one conversation, making one mistake at a time. We used to get super tense whenever a self-advocate scolded us because we got something wrong. It's like, hey, you know, when you talk about a fork in the road on a path, that's pretty ableist because I'm sitting in a wheelchair here. And by the way, your graphic illustrator has some really white visual idioms. It's like, okay, people now will not be flesh toned. They're going to be blue or green or white, you know, like yellow, whatever. We used to get super tense, but now, yes, there's an initial moment of defensiveness, but then we do a happy dance because we realize, yes, Yahtzee, we just learned something and we're going to be better next time. That's where you want to get to.
Well said. I love the strengths-based additive approach. I think it's, you know, what I think you just did, Mai, is also lay out very specifically, very tactically, like here are several things that we can do. And because it is strengths-based and additive, it also leaves people with a lot of hope. So first I want to give you guys a chance to build on that. And then I also want to come back to you, Mai, and ask, so I'm asking you guys, is there anything else we can do, best practices, particularly for healthcare leaders? We're going to get to policymakers in a moment. And then I'm going to turn to Mai and ask, what shouldn't we do? So Brandon, Clay, either of you?
You can go first, Clay.
Okay. Well, to me, as I'm sitting here listening and absorbing, the couple of things that are apparent is that this is a moment of transformational opportunity. And it's also a moment of incredible change. I mean, we look at the weather patterns around the country and the world. We look at the discourse that's going on, and we couldn't be at a time that has more feeling of chaos or change. And I think that it's really a moment for us to try to resolve how we want to address that. And when things get really challenging, really chaotic, really complicated, to me, it's always important to potentially go back to our roots. And I would say a couple of things for you guys, since you are important policy folks, and as we talk about communities and health and building the framework, I think it's important to recognize that at the healthcare worker level, we're having a crisis. We have people in our healthcare workforce who are oftentimes sicker than the people that they are seeing clinically, that they are suffering and they are losing their own health in trying to facilitate other folks' health. And as we go, we've seen during COVID, we've lost a lot of the workforce. And while certainly I don't believe that healthcare and hospitals and clinics is what health is necessarily, but we want that as a good backup, because when we get sick or when we have problems, we need that. So I do think that part of the policy consideration would be to be very broad in defining our communities that we want to approach. And I do think the healthcare workforce is a community that is connected with different specialties, but is a community that we also have to pay attention to when we start to look at the policy changes. Because right now, if you look at the complexity of our healthcare system, most people spend a tremendous amount of time documenting and working on the EMR computer in the room with people. I'm sure you've had that experience, and feeling very, very overwhelmed with stuff to do. And I think that as we go forward and build the framework of a better health system and a better approach, we should also remember that there's a lot of really powerful research out there, whether it's the Adverse Childhood Experience Study, whether it's the work from Elizabeth Blackburn and Alyssa Appel in San Francisco, and I want to touch on that before I finish my comments, whether it's Sir Angus Deaton and Ann Case's work from Princeton, Deaths of Despair and Hopelessness, or whether it is in the data that's coming out around gene networks being activated in 30-year-olds that are consistent with 60 and 70-year-olds based on the way that they perceive their life and their health. And as we look at, and I'm going to touch on Elizabeth Blackburn's data as a part of this, that I think is so very important. So Elizabeth Blackburn won the Nobel Prize for telomeres, which are the ends of our DNA, like the caps of our shoelaces, and every time our cells divide, they get a little shorter. So you can measure the length of the telomeres, and you can normalize that to be able to make an objective assessment of the biological age of people. And Elizabeth Blackburn and Alyssa Appel gathered 39 women, 38 years old on average, high standard of living, San Francisco, highly educated. And it was a complicated study, but I'm going to make just one point on it. So one part of the study is they gave them a validated stress survey, perceived stress survey. And what it looked at was how these women saw the world. Did they see the world as safe and abundant, or did they see the world as threatening and stressful? And if you separated these women, average 38 years old, into groups of high chronic stress perceived on a stress survey or low chronic stress perceived on a stress survey, again, average age 38 years old. Anybody want to guess what the difference in biological years was between the women in the study, the maximum? 17 years. 17 years. And in our state, the worst state for health, the worst county for healthcare versus the best in the country, 17 years different. And so as we look at even things as simple as how you see the world, and we know that Project Aristotle at Google that identified their best teams found that the key element and the thing that separated their most highly productive teams from other teams was the degree of psychological safety on those teams. So the more safe you felt, the more you could be yourself, the more you could be wrong, the more you weren't putting your personal worth out there, the better these teams did. And in fact, the longer these team members are likely to live. So as we design our systems, we should also think about these elements, the healthcare worker sector, but also how we help people see the world differently. Because there is a study in Finland that said that the most important thing in longevity in their study was the ability to think that that is possible for me and I deserve to have that.
Thank you. Brandon.
Yes, thank you. So we talk a lot, I think we talked some in our last panel around patient journey mapping and asking patients and people what it is that you want. So about 3 years ago, we went through a new strategic plan process. And so we had to go to community and say, what is it that you want? Not just in your actual individual healthcare, but even around what the healthcare leader sector look like, what does the healthcare workforce sector look like, and how do all of this work in service of you? We came up with 3 core goals. One was centering race equity, health justice, and power building. And we created a very large strategic plan around it, and our partners in community said that is too much. And so we had to narrow it down to 6 core initiatives that spoke to exactly what they needed, what they valued, and what they preferred. And for them, it came to the first one was putting people over profit. It's too much in our healthcare system today to where profit is at the expense of people and communities' health. We're not against profit, but we're against it at the expense of health and what actually harms people in communities. Then health system innovation. I think we've heard examples, and Mai gave a great one as well, of what it looks like when you actually really listen to people in communities. We heard in the last panel discussion of the real world, very cross-sectional evidence that we get when we listen to patients and to their journeys, and that we can use that data immediately to transform our healthcare systems. We have examples, I think I gave one earlier, of how we use data back in the Financial Alignment Initiative to advocate for broad-scale changes. Coverage and care, I think in advocating, I think many of us in this room push for the ACA implementation and for expanding Medicaid into many states, and not just because that's the right thing to do, but we also know that doing so actually reduce healthcare disparities. We've also heard from when you actually address gaps for historically underserved communities, that is actually probably addressing some of the vast needs for the majority of us. Community first public health, we can still turn to community for solutions around some of our hard scale problems. And I will say this loudly, it's not ever that communities are devoid of solutions. It's not that they're devoid of good ideas. It's that they have been disinvested in to the point that they don't have the resources to align with those good ideas. And so how do we then invest, as I mentioned before, invest those resources so that we can then translate that to social capital and political will. Health and economic justice. We still believe in advocating for things such as paid sick leave and advocating for better pay for direct care workers who provide essential services in home and community-based services. And lastly, organizing people with power. With the first initiative I mentioned around people over profit, I think a really good example of how to do that with community. Currently, right now, we're also advocating for for medical debt protections and policies around that. We're currently, or at least concurrently, I would say, having a Hill Summit, and with folks from the administration, bringing community into those rooms and actually sharing patient stories so that they can hear directly of how this impacts not just their financial well-being, but also their physical health for them, their family members, their household members, and their communities.
So what you're saying is you're blessed with work.
Yes.
All right, Mai, super quickly, anything just popcorn style that we should not do, that we should avoid doing?
Okay, so I actually have a whole hour-long lecture about this, but let me try to distill it for you. We have an initiative we call the IDD Advocate Corps, where we're trying to leverage people like me, I'm sorry, Mike, who come from healthcare, have healthcare leadership positions, but also some personal or clinical commitment to this community. And they keep asking to volunteer, and it's like, we can't slot you in, you have a day job. And they were like, wait a minute, you got a day job. We can leverage that. So again, we brought them together with community members, and we're gonna turn them into an army of insurgents from inside healthcare for change across all the various sectors. Well, as a part of that co-planning work, I led with the question, I feel like we're shadow boxing all the time against something or multiple somethings in healthcare. And I think we need to name the things that we're shadow boxing against so that we can propose the alternatives. So this became our values framework. And the trick is you have to identify the current status quo values in positive or neutral terms. You may not denigrate them because you have to empathize with why they exist. So for example, healthcare worships formal expertise. That's fine, but you should also leverage lived experience and personal wisdom. Why? Because over time, that will actually make you, clinician, more expert in how to take care of me.
Amen.
Healthcare worships efficiency. It's a false efficiency to cut visits short, to focus on a clinical problem list, because all you're doing is laying the groundwork for mistakes, for not solving problems that are going to come back and bite you later in the form of avoidable ED visits or mental health crises or whatever. That's not efficient ultimately, right? We're shadow boxing against profit, but for the wrong reasons. Again, we don't mind profit if it's rewarding outcomes that matter. And that worshiping of clinical expertise is also that combined with what I would call slicing and dicing people's multiple identities, that scientific tendency to be reductionist. You are a walking heart attack that I need to prevent from having the second heart attack. Therefore, I will focus on getting you an aspirin. I've checked my little NCQA box or CMS box, but I didn't ask you what was most important to you in the next 6 months, 72-year-old male partner of mine. And it turns out all you wanted was to be able to get to your granddaughter's wedding. I didn't help you with the wheelchair. I didn't help you with transportation. You didn't make the wedding. You got depressed. You stopped taking all your meds. I did great on my scorecard. Patient died. Okay. And then the last thing I'll leave you with, don't do, is please stop worshiping the average healthcare user. We are obsessed with the median user. It shows up in all of our metrics, our benchmarks. It is how CFOs walk around thinking in health systems. Even when we talk about research studies, it is all about the median, right? We're calculating p-values based on the average for the intervention group and the average for the control group. Guess what? None of us actually live right there in the middle of the bell curve for more than a hot New York minute. This is why universal design is the only path forward, because we will all stretch across that entire bell curve at some point in our lives. That is why none of the outcomes that, none? Let me just check. Maybe 2 of the outcomes that were identified in our stakeholder group can connect to clinical guideline-driven metrics. Mm-hmm. Who were those guidelines developed from and for? Who do they serve? They do not serve any whole person. They don't even serve my 84-year-old Vietnamese-speaking, hard-of-hearing mother, because who cares what her hemoglobin A1C is? She can eat whatever she wants, right? I care that she doesn't gain 10 pounds of fluid only because then she can't walk. The point is she wants to walk, not that she wants to keep her weight at a certain level. Help her walk. Yeah. And if the guidelines can be in support of that, have at it.
So let's turn to policymakers, since this is our kind of illustrious audience here at the Alliance for Health Policy. My sense is there's a continuum of engagement methodologies for bringing community voices closer to policy making. Brandon, you've mentioned a couple of them. We run a community-powered problem-solving model for local elected officials, so not like county level. And we started by doing something we call a lived experience ambassador forum. Just get 12 people in a room. In this case, we did mental health access for people in crisis, and we listened to them. I think a lot of people would stop and then they would translate what they heard to the policymakers and the stakeholders doing the work. So we didn't do that. We did that, and we brought 3 individuals into where the work was going to happen, who sat at the table, who rolled their sleeves up with us, with the policymakers, and then the local stakeholders who really had to implement the work. And it was a profoundly different conversation than it ever would have been, because you could hear the stakeholders and the policymakers like going back and forth and nerding out on all the data. And I'll never forget it. Tyler raised his hand. He goes, yeah, listen, here's the deal. I know where to buy drugs in my community. I do not know where to get help. That's what we need. So you guys debate all you want, but I need to know where to go, and we need to build like a one-stop shop where I will mobilize the entire community. In his case of people in recovery, we will supply the transportation, but we need a place. And that shifted the entire conversation. They went out, they got a grant, the county did some work with their policies, and that's what they're building today. And so talk to me about what can we do? There's a big continuum of engagement. That's one example, not by any means perfect. What can policymakers do? Policy is a very blunt instrument at the same time. So I remember there was an ACA provision that required the HHS secretary to evaluate delivery models under what was a Title III according to patient-centered criteria, but no one knew what that meant. So what can policymakers do?
Got a list here. So.
And we have about 2 minutes.
Okay, so I'm talking really fast. So listen, if you're a policymaker who wields resources in the form of Medicaid 1115 waivers or other DSRIPs, if you have CMMI grants to give out, NIH grants to give out, insist in exchange for those resources that whomever is on the receiving end actually have authentic engagement, and they tell you what their processes are, that they have letters of support and commitments from actual people, not theoretical categories, by the time they submit their application, that those people are getting compensated for the expertise and contributions that they're going to offer up. That's super concrete. I would also say, to Elliot's point, I think I would even push Elliot a little bit. It's not about patient-reported outcome measures. It is about goal-oriented metrics. You don't have to go back and again and again and again to the patient to measure the things that are important. Some measure developers have come to recognize our entire measurement industrial complex has generated things driven by clinical guidelines that don't actually link to actual outcomes. So now they're shifting to saying, okay, what's a more generic person-specific way we can measure this? For example, a metric could be, did you elicit the patient's goals? Did you document it? Did you come up with a plan for how to get there? Do you know what the milestones are on the way to that plan? Where on the milestones are they? Did you get to the goal? Hooray, right? That's a scale. We can do psychometric testing on that. We can have a goal bank. Not everyone needs to have the same goal. That's a whole area of policymaking. And then the third thing I would say is policymakers need to examine their own culture, because I do not believe that, they of course, legislators are used to having advocates and community members and constituents show up and tell them what's important to them. I don't believe that CMS has built that mechanism. Mm-hmm. I know we didn't have it. Mm-hmm. We were very well intended, but like in my head, building Pioneer ACO model, like how was I going to sit down with actual people? You know what? I could have. Mm-hmm. It's not that hard. It really isn't. Mm-hmm. Just do it.
Would you guys add anything to that briefly before we open it up for Q&A?
Yeah, I would briefly add to a few of my points. One, I think we could probably think about, if we think about quality metrics or even star ratings, I think it may be time to have industry report back exactly how you're engaging communities and your patients, and tie it to payment in some way. Mm-hmm. I think that's what makes folks move these days. Secondly, around valuing lived experience and expertise, there is one barrier that we face, and that's that we try to equitably compensate folks for their time as well. But if it's around $600 threshold of once they've received that in any given year, they must then file a 1099 form with the IRS. What that can do is put you above a threshold if you depend on any means tested benefits or any entitlement benefits. So that's a really large scale problem that will take probably policy making innovation at the federal and state levels as you consider things such as Medicaid, SNAP, WIC, housing benefits. Because if anything, we certainly don't want to be involving people in ways that's going to unintentionally harm them.
Yep, hear, hear.
And the only thing I would say, and I know we're at time at this point, is again, when things are really complicated, to me, try to get simple. And what we're trying to do in West Virginia is to try to help train people to be able to find a job that's going to help them connect to community, to gain income, to support a family, to gain social capital, and to have a higher level of purpose. And we believe that is the thing that will translate the best to a change in the way they see the world and their health.
Beautifully said. So, audience Q&A. All right, we've got mics, I think, that come around. And we've got, it looks like double trouble from that row. I love it.
We roll deep
Bring it
together. Good afternoon, morning. I'm Allison Sullivan, and I work in migrant health. Key question for you, both the first panel and this panel really highlighted the intense involvement of communities and partners up front in the process as the good idea factory and listening. But oftentimes what we have heard from our communities is you come and you take everything and then we never see you again. We never see you again, right? I sat in that session, I gave you that good idea, maybe I get a thank you note, maybe I see a journey map, but nothing. And maybe in 2 or 3 years' time, I see a program. How do we close the loop? How do we create policies and programs that look at communities as a source of implementation and scalability and not just good ideas?
I know that for IAC, all I can say is once they're in, they're in. I mean, they're in for the long ride. That's just how it is.
I also think personally, I think we have to get over you. I didn't hear it, thankfully. Thank you, Hala, and your panels this morning. But the whole bias against what they call professional patients, we have to get rid of that. Everybody in this room gets paid to do a job, right? And so we have people like Hala, who she's not getting paid to do this job today, right? She should be, and we should not bias people against the advocates who are willing to make a living out of being those voices. But I also think that we heard from the earlier panel too some great community infrastructure that can plug into that all along the process, whether it's community health workers, but the involvement of community agencies and people who stay close to individuals. So I think you're making a great point.
Can I just add, I will say, I should have said in the list of things not to do, don't get their input and then not act on it. There is no faster way to burn trust.
Yep.
Funders, if you're listening to this, we actually need to find the metrics to support the health outcomes framework. We can't just elicit what's important and then put it on a shelf.
And I would just say also, I think you have to dial in, I agree with what you said exactly, but I think you have to dial in an evergreen mechanism. So there has to be a way that you can leverage what the idea is, what the grant is, et cetera, to create a sustainable revenue stream that continues to reinvest in the community leaders. Because if you can't do that, you will have a lot of start, stop, and you lose trust. I mean, trust is gained over a long time and lost in a second.
And to quickly add to that, one is building in feedback loops so that it's continual. Two, I believe it's building the capacity of community leaders so that they actually understand that you're not obligated to just give your trust to us. That we should actually have to build that, and we should have to first demonstrate trustworthiness. I always go back to almost a scriptural reference. It's my first love is theology, but it says that you should not cast your pearls to the swine. I feel like in communities, our pearls from our trauma, from our harm, from our disadvantages have been our trust. And we've been asked for too long to exchange that and give that to institutions who have harmed us. So with that, I think building community capacity for that, and then making sure that those relationships that we build are not transactional. If they are, then we should be clear about that. But I think too many institutions have been co-opting, co-design, empowerment, type in movement language in efforts to get funding and to get community involvement. But if it's simply transactional, be authentic in that and state that up front so that communities do not feel as though the relationship is exploitive or extractive.
Thank you.
Thank you.
Hi, Katie Kozlowski. I also work in migrant health. Big surprise. My question, I really love the conversation around some of the compensation and trust building, but I'm thinking about some of the communities where there are real barriers outside of just trust that may make it difficult for those community members to engage in this type of co-design sessions, whether it be undocumented immigrants or those that are in the criminal justice system. Do you have any thoughts on how we can better engage those populations and make sure they are represented in some of this co-design effort?
So I think I would build on something that Maya talked about earlier. We do a lot of asset mapping, and so when we work in populations, prison for example, it's easy to sort of, oh, well, we can't engage them because, and there's but if we flip the model to a strengths-based approach, right, what is their journey map? What is that life like? And where are those touch points? What assets do we have? How can we creatively find a way? I'm reminded of the work of Open Circle, who found a way to bring prison guards together with prison inmates to rebuild relationships from within. And it was beautifully powerful. And no one thought it could be done, and it was.
Yeah. So we have not yet tried to approach prisons. I don't think we know enough, frankly, yet. And we're a small group, so like if we were allowed to and we had the resources, of course, we give an iPad or a tablet to anyone because most of our work is virtual and digital. But we don't have any barriers for people who aren't documented to participate. We ask questions in our recruitment to help us maximize diversity. And we always give people the option of not stating. Don't want to state your gender identity, that's fine. But if you do, then we can use that in making sure that, you know, we get disproportionate representation from underheard subgroups. But we try very hard to not put up barriers.
Brandon?
Yeah, I would say that it's probably one, engagement in ways to provide direct feedback is synonymous, I would say, or at least parallel with engagement with the overall health sector, period. And I don't think that we could, I think it harms us as a society, as institutions, as individuals, when we do not consider the historical context, when we do not consider the lived experience of individuals and communities and how that allows access or not. I'll give three very quick examples if I can. One, I'm originally from the area in Louisiana called Cancer Alley. Between Baton Rouge and New Orleans, 40-mile stretch, predominantly African Americans end up with a cancer diagnosis because of our proximity to industrial chemical plants. That itself has probably led to more people in my family. We'll take all of our hands on this panel, and probably a few more, to count the number of persons who've had cancer and who've even died from cancer. My mother, who worked her whole life in the healthcare industry as a phlebotomist and as a nurse, end up getting cancer. Also didn't end up with this heat-seeking missile came to this area that we call COVID-19, which capitalized off of undiagnosed respiratory illnesses. Gave us also the highest COVID rates and high COVID deaths in the nation. And my mom, they almost cannot get access to personal care or a direct service worker because it's such a rural area. And then Harvard does this study and showed that had reparations actually been in place in this small area, because of it's such a mix of race and place and history and how health pathogens per se, or viral pathogens, capitalize on all of that, created such individual and community level harm. But had reparations been in place, it would have averted, that they scaled it to the rest of the nation, it would have averted at least 100,000 deaths related to COVID for Black Americans in the US. All that to say, all those different pieces and social factors influence the way that we can or cannot engage. And it harms us to not consider that historical perspective. And I would urge healthcare leaders and policymakers to think using an asset base on what these communities do have so that we can engage with them so that folks can get the health care that they need.
And we are going to end on that. That was awesome. Thank you guys for joining me today. Thank you. And I think we go to break.